muted at first.
I tell you what, I say the best things when I'm on mute.
That's brilliant. So moving into the question. I was going to say, thank you for that great talk. I won't lie, when I saw noncompliance in the title, I'm like, I wonder where he's going to go with this, because that's a term that I kind of hate myself.
Me too.
But I'm really excited that it went where I thought it was going to go. I'm
glad.
Enough about me and my thoughts. I'm going to go ahead and bring up some of the questions. I think this is more of a comment than a question. So as you gain skills in difficult conversations, you don't have to seek them out. Your colleagues who are aware of you will try to send plenty of people your way. Any thoughts on that?
No, I think that's true. But I think, look, I feel like some of these skills are skills that everyone should have at some level, right? So one of the things you can't do is, like, in your workspace, wherever that is, or whatever your job is, whether it's your family or your clinic or whatever, you can't be the only person who is capable of handling a difficult interaction with someone else. That is not a reasonable expectation, right? So everybody needs some of these skills. And I really have tried to, like, leave a lot of the theory and conceptual kind of things behind and just focus on some actionable steps that people can do. And so I'm hopeful that this was helpful in that regard.
And possibly the start of a new dance craze, which we may cover in a bit. Okay. What would your suggestions be for handling a patient who may be malingering because they enjoy the social aspect of attending medical appointments? This patient did not have family and did not work.
Okay. Well, so here's kind of how I look at this thing. So, like, I have no idea what people's motivations are for doing what they do, and neither do you. So the question is not, how do I feel about what I think they're doing? The question is, what am I going to do? What is my role here? And for me, I'm trying to do the best I can on my variable of helping other people get better. And once I have gone as far as I can go, and I can't help someone anymore, it's time to move that person on. And that has nothing to do with them. It has everything to do with me and what I've done and a situation where I've taken someone as far as I can take them. It sounds like therapy is over for that person. And so you need to move that person on, not because you think they're malingering, just because that's the phase of the recovery that we're in, right? And so I think, we don't have to try to figure out why other people do what they do, or try to play Nancy Drew and the Hardy Boys about people's motivations and behaviors, right? And so those were mystery books a long time ago, if you're too young to know who those people are. My wife always says, you always use these old man examples. Gosh, she's right about that too. Anyway, so that's kind of what I want you to do. I want you to focus on your part of this interaction, right? So regardless of what somebody else does or does not do, my job is to maximize that variable of clinical care. And once we're there, it's time to move on. And that's something that's going to be good for you and good for your patients as well.
Yes. And if I could ask your thoughts on something else along that vein, is like, so if we're thinking, and I have to apologize, there was like a little bit more like explanation after that. I'm still getting the chat down.
I got it.
But that maybe, right. So like, as physical therapists, right, we have some of that, we're talking with people, we're dealing with people. And also if we're their only support system, that it might be, that's outside of our scope, being their entire support system. And
it's outside of everybody's scope in medicine, right? That's
correct.
not a medical care scope, right? That's not what we're here to do in medicine, right?
Right. And part of like the bigger picture, right, with getting those social issues and social support necessary, and kind of bringing in like the rest of, you consider interprofessional or team to help people get the resources they need. Because I know part of your heart wants to do that. It's like, oh, you need help, I want to help. And also, I can't do that help. So moving on from that point in their recovery, and also again, perhaps moving to their next place for assistance.
Yeah, I would just say, like, even putting our mind in this space is not useful or healthy, right? It's not. I don't think it's helpful for me to like come up with all the reasons why I think somebody is here for the social aspects of therapy. Like, that's mental time and space that is not useful to me. And it's not helpful in my interaction with the person either, right? So it's like, hey, look, we've done everything we can. I've taken you as far as I can take you here with therapy, and it's now time to kind of transition to self-management. And that's something that we have a responsibility to do in medicine, regardless of how we think we think the person is doing here, what all that stuff. It's just irrelevant, right? And it also has the potential to rupture the therapeutic alliance that I have with the patient when I try to put myself in this situation. So even if you find yourself listing out all the reasons you think someone is here for bad reasons, you're already in a bad place, right? It's a good time to recognize that and say, ooh, this is not a useful place for me to be as someone who's here to help and to be in service to others. This is not a healthy place for me to be. I need to turn around and go back.
Yeah, I love that. And you said something, and I think I'm not going to get it quite right, but like the whole goal of, well, hopefully healthcare in general, but certainly physical therapy is getting them to that point of independence, right? So where they can go and do the things that they need to do, even if they're not perfect. And I wonder how much that is or isn't a part of a lot of our training. Is like, so when are people done? Because I think, at least here in the States, just Sarah's opinion, is that very often it's more based on like, well, your insurance visits are up for the year, right? So like finding that spot and aiming for that target of, how do you feel about not seeing me on a regular basis? And what are the steps we need to take to maybe get you there?
Yeah, no, I think that transition is hugely important. I think you're 100% right. You're exactly spot on. And so I think regardless of where you go, like, one way to look at medicine is like, can everyone have all that they want? No. Doesn't make a difference where you live. Doesn't make a difference what your medical care situation is, right? In my time in the military, I worked with many senior military officers from other countries' militaries. Everybody's medical system has the same problem. Everyone's medical system has the same problem, right? We are all running out of money, and we are all struggling with ways to provide the best care we can with what we have, right? And so that doesn't change if you're in Norway or the US or the UK. The problems are the same. The question is, how do we solve them? And a big part of it for us, regardless of the whether you're in physical therapy or sports medicine or massage or whatever, we have to get to that point where we're moving people to that self-management step. And that, you're right, that should be independent of, what some of the other things are. It needs to be solely focused on a clinical and self-management goal.
Absolutely. And that, it's funny. So that takes me back to another time where you were, I think, here in Chicago, and showed me the best infographic ever about like not being able to outrun a bad diet, and how like taking care of ourselves, if we spent more, effort, time, money on figuring out like what is healthy and what can I be doing, as opposed to just let's get fixed and send you back to wherever you were.
Yeah, awesome. So I know the infographic you mean. It's from the Bipartisan Policy Center, and you can look it up. And I've got it up on Twitter. It's from their report about obesity in America. So basically, the substance of the infographic was this: we've made this huge investment in medical care, and we talk about health, and that's what we talk. Even when we talk about medicine, like, well, what about healthcare? Like, folks, medicine ain't healthcare. That's medical treatment, right? Most of what happens with healthcare is your environment, your genetics, which you can't really control too much. But a big chunk of it is people's personal health behaviors. And we have just underinvested in the place where we have the biggest potential to help people get better. Now, if you're watching this and you're in the San Diego Virtual Summit, you've already heard people talk about things like sleep and other things that are huge and crucial and awesome. And that's why you're ahead of the game if you're watching this conversation right now. But that's kind of where we need to go. We have overinvested in places where we have the least ability to influence, which is in the medical treatment sense, right? And so we've got to change that conversation, both interpersonally and nationally.
Yeah, I love that. And so you're in the military, where the population is, I don't know if this is a fair thing, but definitely like their fitness levels are tracked much more regularly and all these things.
Most definitely.
Do you see, between the civilian world and the military world, do you see more money or more effort being invested in that idea of health as opposed to medicine? And does it work?
Yeah, so great point. I would say that we are definitely in the middle of an evolution that way in the Department of Defense in the U.S. military. But some very encouraging things are beginning to happen. One of which is the U.S. Army, the largest service by far, has. Sorry, I had to throw that one in there. Has rolled out this thing called the Holistic Health and Fitness Program, which is designed to do exactly what you're talking about. It's designed to proactively manage soldier health and readiness. But I would say generally, military people aren't different than civilian people. People don't stop being people when they put uniforms on. And so we have this sense that military people are, oftentimes unfairly we kind of put them on some sort of undeserved or unfair, unhuman kind of pedestal about stuff. And I'm just a person like everybody else, right? And we're all kind of doing the best that we can with what we have.
Awesome. Okay, so we're so we still have a little bit more time for questions. If anyone is interested in getting them into question at sandiegopainesummit.com. But I'll ask, what else now that you've watched? I know that you didn't make your video too long ago, but is there anything you're like, I wish I would have maybe gotten that
thanks.
in there?
No, great question. If anything, I think sometimes I try to cover too much at once, and I hope that this wasn't too much for people. But everybody's got what they want to emphasize, and for me, always it's about practical application. If I'm giving you something that is not immediately practically applicable, I'm asking myself, what am I even doing here, right? And so, I know, there can be some benefit in talking about, the philosophy or the concepts behind something, and I'm not opposed to that at all. And I think that can be healthy, but it's usually not useful. And what I want to give people is things that are useful, that they can immediately implement. And so I do hope we get some questions. And I put a tool up on the screen when I first started that I thought would, maybe make people feel some kind of way and make them feel uncomfortable, that little hunk of metal that's kind of scary, right? And so we can definitely talk about that or about other things. That was a deliberate effort to get people to have that hit, that sort of that adrenaline dump, that oh my gosh, because that's what happens when difficult conversations happen. Sometimes you don't see them coming. Although when you understand this stuff, you get a little bit better. But sometimes you don't see it coming. And then when it happens, what skills and strategies do you have to manage what you're seeing, right? And so I'm hopeful that the systems that I went through and the content that we reviewed today helps you feel more prepared to deal with difficulty when it happens.
Yeah. And, and I think that's another thing in our training, at least I'm speaking from a very physio-based background, is we don't really get much training to be prepared for the fact there are really hard days and really hard conversations to be had. So I really appreciated that concept of being prepared. And if I have them talking, I can get them walking.
If I can make them talk, I can make them walk. That's the thing we say in self-defense, right? Is that's what I want to do. I want to talk. I don't want to have the physical stuff. That's a failure in my mind, right? Mm-hmm. That's my whole goal, is to avoid that kind of stuff. Mm-hmm. I want to resolve this other ways. And it's the same thing with patients, right? We want to be proactive with patients and colleagues about managing that stuff. And in medicine, in nursing, in PT, in massage, we don't often, as part of our training, we don't have a lot of deliberate, hey, here's how to have tough conversations with people, right? What happens is we put people in that situation, go, good luck, and then we give them some feedback about how they did, right? Instead of giving people strategies to actually proactively manage that sort of thing. And that's really what I'm trying to do, is to help people be able to function better by giving them some of those practical skills.
Awesome. So we do, perfect timing, have a follow-up from the question that came in earlier. I'm the submitter of the malingering question. I wanted to make sure I emphasize that everything I put wasn't assumed, but admitted by the patient. Does this change your recommendations in any way?
No, I appreciate your clarification. And I definitely appreciate the person who's putting that out. And I think that what I'm picking up, which is implicit, is they're trying to reassure me that they were not thinking negatively about the patient. This was something that the patient openly brought up to them. And ma'am, sir, I get it. And I haven't assumed anything negative about you, but I have to tell you, none of that stuff matters, right? Whether the patient admits it or not, whether I suspect it or not, it's irrelevant. That does not change my behavior, and it doesn't change my responsibility either, right? And so kind of what animates me every day at work and in whatever environment I'm in is not like what I have to do or my task list or whatever. It's what my responsibilities to other people are and how I can meet my responsibilities to other people. And I have responsibilities to them. And the responsibilities I have for my patient is to do the absolute best I can do, is to make my one variable, it's just one variable of clinical care, as good as it can possibly be. And we have either maximized that or we have not. And if we have, it's time to transition. Nothing else matters. Not the insurance money, not whether or not we think they deserve it or they're making it up, or whether or not they're here for social. None of that stuff matters, right? If they came to me on day one and says, here's the deal. Like, I don't really want to do therapy. I'm just here for a social thing, and I'm charity covered, and I'm just here to say hi and meet people and have a cup of coffee and all that stuff. And I'd be like, oh, great. Talk to me about what your goals are. We try to work the therapy thing. Once I get a sense that the therapy piece is maximized, then it's time to move to self-management. 1 visit, 3 visits, 10 visits, doesn't matter, right? That transition, that responsibility doesn't change based on all those things. That's why I think even talking about that stuff, even thinking about it, just isn't useful.
Awesome. I will also toss this one up here in our last minute. Great prop on the gun. And I do need to apologize. I'm supposed to make you like the only picture on there, and that gun would have been way bigger if I would have done my job better.
Do you want to see it again?
Oh, here, wait, hold on.
It's okay. It's okay.
The big one.
If you want a screenshot, here's your chance, right? There we go. Just a tool, nothing to be afraid of. But here's the deal. So when you get difficult conversations, you're going to feel something sudden, and it's going to make you feel uncomfortable. And the question is, do you have the tools and strategies to manage what you're feeling and to move through the interaction, right? And so just like everything else, being prepared for something doesn't mean you seek it out.
Love it. And then, of course, we did get a bunch more questions, but we are also out of time and need to mosey on over to Zoom for the backstage pass holders. But so everyone who did get a question in, but we did not have time to address it. Jason did tell you how to find him online, so check him out on Facebook or Twitter or Instagram or TikTok or LinkedIn.
Excellent.
Thank you. The TikTok surprised me, but
well played, ma'am.
Just because
I want to be everywhere people are. I want to be everywhere people are. And if that's where they are, then that's where I want to be too.
I love it. Okay, well, some people are going to be over on Zoom. I'll go open up that meeting. Everyone else, we will see you in a bit.